So now I have a question to the audience. And so for glucose control, how would you adjust Maria's treatment regimen? And here are now 6 different options. And option A is add a sulfonylurea. B, add a DPP-4 inhibitor. Option 3, add insulin. Option D, add an SGLT2 inhibitor. Option E, add a GLP-1 receptor antagonist. Or F, add a thiazolidinedione. This was maybe the expected result. And of course, for glucose control, most of you would like to add a DPP-4 inhibitor, which I can underline to and sign up to. Some people also say that we could add an SGLT2 inhibitor. And absolutely both of them are correct. But in this particular case, the patient doesn't have established cardiovascular disease. It might be a matter of time because she's hypertensive, she has a reduced eGFR. So I would not say that an SGLT2 inhibitor is a bad choice. On the other hand, we don't have hard evidence yet showing that an SGLT2 inhibitor is effective in terms of preventing cardiovascular disease in primary prevention. So this can be considered to be primary prevention, but time will tell. But most of you, 91%, would add a DPP-4 inhibitor, and I would agree with that suggestion myself. So if we agree that a DPP-4 inhibitor, then the question would be, why not combine that? So a single pill combination with, for instance, linagliptin. Could that be an option? Or why it could be an option? And the question now again goes to the audience. So why might a single pill combination with linagliptin be an option? First of all, we have to keep in mind that she was already on metformin. That was the background therapy for her diabetes. So option A, to improve Maria's glycemic control, would the single pill combination be an option to improve the glycemic control? Option B, to avoid need for monitoring or dose adjustment should her kidney function decline in the future? Or option C, to avoid increasing pill burden and help her adherence? So we'll look at the results. Why might a single pill combination with linagliptin be an option? 62%. To avoid increasing pill burden and help her adherence. I can agree with that because a single pill combination reduces the number of pills at least with 1 less. So you combine with, for instance, metformin here. 38% to avoid need for monitoring or dose adjustment should her kidney function decline in the future. Linagliptin would of course be a very good option in terms of no need for dose adjustment. But I will talk you through what decline in renal function also might bring with it with the single pill combination. So linagliptin is available as a single pill combination with 2 different doses of metformin. On the left hand side we have the 850 milligram of metformin. So this is meant to be taken twice daily. So 5 milligram of linagliptin and 1 gram 700 milligram if I do the mathematics correctly. Per day. And then on the right hand side we have the 1 gram of metformin in combination with 2.5 milligram of linagliptin. So twice daily means 2 grams of metformin and 5 milligram of linagliptin per day. So these are the available single pill combinations. And of course the twice daily dose allows maintenance of the same 5 milligram dose of linagliptin, which is the dose we have been used to use with linagliptin, and we say that we can use one dose once daily without any problems in any patient with type 2 diabetes, irrespective of the characteristics they come with. But of course, if we consider the single pill combination, then because of the metformin, we can also split the linagliptin into 2.5 milligram and combine with metformin in 2 different versions, and we can prescribe it twice daily to the patients. So Then the question is, what about the DPP-4s, and why should then linagliptin be part of that single pill combination? This slide shows quite clearly in a study where 83 randomized controlled trials were compared, and we can see that all the DPP-4 inhibitors are effective. They reduce the A1C by 0.7%, and now we have to keep in mind that these are not head-to-head comparisons. But we can see that they are all in the same ballpark. So all DPP-4 inhibitors are efficacious in terms of reducing the A1C. Then what about then the single pill combination, so add on to metformin? And this slide shows quite clearly that if we, on the left hand side, if we give metformin as monotherapy here, or if we give linagliptin in combination with metformin, we can see that you have a stronger effect on the A1C. And of course, in terms of being able to improve the glycemic control, in a lot of situations, this could be a useful combination and a useful option for the patient. Linagliptin and in combination with metformin also provides sustained efficacy up to 2 years. This slide shows that up to 2 years. We can see that after the initial drop here, we can see that we have a very sustained effect of the combination. And of course, this is in comparison with the combination of glimepiride, LSU and metformin. And of course, we all know that glimepiride is a very efficacious glucose-lowering medication, but it comes with a lot of strings attached, with the increased risk of severe hypoglycemia. And of course, here we can see that a combination with a medication that does not cause by itself an increased risk of severe hypoglycemia, we can achieve exactly the same result without the risk of hypoglycemia, and of course also not the risk of weight gain. And if you look at the safety profile, because of course when we combine medications, for polypharmacy, we need to look at, do we cause harm? And you can see here that across all the potential side effects here, there is no more side effects with linagliptin plus metformin than if you compare placebo with metformin. So I would say that we can definitely agree that linagliptin is a simple option for Maria, and most of you opted for a DPP-4 inhibitor to improve her glycemic control, and of course also and then in combination with metformin. So if you then change Maria's treatment regimen from metformin to linagliptin metformin single pill combination, what do you achieve? In Maria's case, 3 months later, what was seen is that her A1C had dropped to 7%, which is something that we wanted to achieve. So this was not only the expected result, but also the result we wanted to see. And of course also, I think it's a convenient treatment regimen. The number of medications was not increased. It was actually that's something that we need to. It was not either profusely reduced, but at least we could achieve better glycemic control without increasing the number of pills, which is, of course, good news for the patient, and will definitely also improve the adherence. So I was talking about at the beginning of the presentation that age comes with losses, and this is now a combination of males and females, but we can see that aging actually makes us lose kidney function. And again, at the age of 60, you can see here, it's already reduced here, but this is a combination of males and females. So if I would draw this picture separately for females, it would be lower, and then we come to the fact what I said, 1/4 of females without any disease will have an eGFR by definition below 60, so by definition CKD, and at the age of 80 every second one. So this is something that I want you all to keep in mind, that Diabetic kidney disease is common. The consequences are grim. We always need to monitor the renal function. And whenever we see a reduction in renal function, we also need to then make sure that we are not using medications that are accumulated, or if we are using them, we have to give the patients the right dose in order to avoid the accumulation.